Hello, and thank you for listening to my DNP Quality Improvement Project presentation regarding advanced care planning in patients diagnosed with chronic obstructive pulmonary disease, or COPD. Advanced care planning are voluntary discussions of advanced directives between a clinician and a patient, family member, or surrogate to prioritize treatment goals. These discussions are vital to patients diagnosed with COPD due to its unpredictable disease trajectory and chronically debilitating symptoms. A site assessment of a primary care facility was conducted in June 2019, in which analysis of the health system and care process demonstrated lack of documented advanced care planning discussions within electronic health records, leading to unwanted interventions and costly hospitalizations. Guidelines exist that recommend engaging in advanced care planning in the early stages of a disease. However, there are no state regulations or standard operating procedures within the facility to mandate this. The goal of this QI project was to increase advanced care planning discussions in COPD patients as measured by documentation in NextGen from 11% to 14% in 3 months. A literature review was conducted of 11 scholarly articles. The most effective was an observational study based off of a parent randomized control trial in which clinicians and patients both received the implementation. This QI project reflects this in a time-sensitive and cost-effective manner. The quality improvement tool was created by this DNP student, in which was a 10th grade level educational pamphlet and an identical poster board displayed in the office for patients regarding topics of their disease process, advanced care planning, and how to have these discussions with a clinician. Once approval was obtained from Quinnipiac's Scientific Review Committee in November 2019, the staff were educated with a PowerPoint presentation and identical poster regarding the QI tool and their rules. Implementation then began and utilized the diffusion of innovation theory. COPD patients received pamphlets upon arrival to the office. Data of advanced care planning documentation was collected at each monthly interval. Feedback from staff was communicated through biweekly emails and monthly meetings. 9 months of data was collected, 6 months pre-implementation and 3 months during, which focused on the number of advanced care planning documentations. Throughout the 3 months, there was a total of 5 documentations completed by 2 clinicians. Although there was somewhat of a modest increase from 11% to 13.5%, the run chart illustrates the data points are independent and represent random variation without any statistical significance or pattern. There was no significant measurable change compared to the pre-implementation data, and the SMART aim was not achieved. Other data collected measured the different insurance carriers as shown in the bar graph. This was addressed because the advanced care planning services are reimbursed by Medicare and Medicaid. The pie chart illustrates different types of visits that were documented and billed during the 3-month period. Suggestions for future practice to improve this process include creating a mandatory program before the implementation to enhance staff education and compliance. The electronic health record can be utilized to remind providers to have discussions. This innovation could be applied to other primary care and specialty offices, as this encompasses different staff, stakeholders, and patient demographics. Patients with other chronic or progressive diseases can also be included. Lastly, this QI project with the suggested changes could be implemented for a longer period of time, which may produce statistically significant results.